I was shocked. So many kids were being hospitalized for asthma. In fact, asthma was the number one reason children were admitted to a hospital. That really hit me. I remember thinking asthma is treatable. So why are so many kids ending up in the hospital? And that moment was a turning point for me. It felt unacceptable. And I wanted to understand why it was happening. And more importantly, what we could do about it. And that's what really sparked my curiosity and commitment to asthma research.
Welcome to Beyond the Wheeze, the podcast where perseverance meets potential. I'm Josh Realm, public speaker, marathon runner, asthma advocate, and your host as we explore the intersection of health, fitness, and resilience. Whether you're managing asthma, chasing a new personal best, or simply looking for inspiration, Beyond the Wheeze is here to show you that no challenge is too great to overcome. Together, we'll uncover stories, insights, and strategies to help you push beyond your limits. It's time to breathe deeply, move forward, and unlock your true potential, one step at a time.
Today I have the distinct privilege of welcoming Dr. Teresa To to the show. Dr. To is a senior scientist at the Hospital for Sick Children, a professor at the Dalai Lama School for Public Health and Institute of Health Policy, Management and Evaluation at the University of Toronto, and an adjunct scientist at ICES in Toronto. For the past 3 decades, Dr. To has become one of Canada's leading experts in population health and pediatric asthma. Her groundbreaking research has illuminated the ways that early life exposures, such as air pollution and tobacco smoke, influence the development of asthma and other chronic respiratory diseases in children. She's also a passionate advocate for equitable care and access to treatment, working tirelessly to ensure that children from all backgrounds have the support they need to live full, healthy lives. Dr. To leads the OASIS Research Program, that is OASIS, Opportunities to Advance Screening and Integrated Services for Children with Asthma. And she's a founding member of the Canadian Respiratory Research Network. Her work has influenced clinical guidelines, school-based asthma education, and even national public policy. Beyond the data, she's known as a mentor to many young researchers and a tireless voice for letting children be children. Today, we'll explore her journey through research and advocacy, the vital role of early intervention in pediatric asthma, and the impact of mentorship, data, and compassion on shaping healthier future for kids. With that being said, Dr. To, welcome to Beyond the Wheeze. It's so great to have you.
Thank you, Josh. Thank you for having me. Pleasure to join your podcast today.
The pleasure is entirely all mine. I was very fortunate to meet you this past May 6th, which is World Asthma Day. We met at the Mercado in Toronto. You were the keynote speaker. I believe you had a 15 to 20 minute speaking slot. To be honest, I could have listened to you all day, and I think a lot of people there felt the exact same way. And we actually had a conversation just before you got up to do your speech. And you had mentioned that, 15 to 20 minutes maybe isn't too long. So I then proposed, well, why don't you come onto the podcast and we can dive in just a little bit deeper.
Wonderful. Thank you for giving me this platform to share my thoughts.
Absolutely. And I'm so excited to dive in. And I know you're a busy person, so we'll dive right in. So I'd like to start off with understanding pediatric asthma and early intervention. Dr. To, your career has focused on improving outcomes for children with asthma. What initially drew you to this area of research?
That's a great question. What drew me to asthma research? It will have to go back to more than 2 decades ago when I first started at Sick Kids. One of my early tasks was to assess or quantify the burden of asthma in Ontario. I thought it would be quite straightforward, right? Just counting some numbers and reporting them. But when I actually saw the numbers, I was shocked. So many kids were being hospitalized for asthma. In fact, asthma was the number one reason children were admitted to a hospital. That really hit me. I remember thinking asthma is treatable. So why are so many kids ending up in the hospital? And that moment was a turning point for me. It felt unacceptable. And I wanted to understand why it was happening. And more importantly, what we could do about it. And that's what really sparked my curiosity and commitment to asthma research.
Your research explores how early life exposures like air pollution or secondhand smoke can influence the development of asthma. What are some of the most critical early factors that clinicians have and families should really be aware of?
That's a great question. There are quite a few early life exposures that can influence the risk of developing asthma, and knowing about them can really help families and clinicians take steps early on. And as you know, Josh, one of the big ones is tobacco smoke. We know that if the mother smokes during pregnancy, or if a baby is exposed to secondhand smoke early in life, all of that increases the risk of asthma. But interestingly, here's even evidence that suggests if a grandmother smoked while pregnant with the mother, it can affect the grandchild's risk of developing asthma. And that's likely due to what we call epigenetic changes. That is how genes are switched on and off across generations. Another one is feeding practices that may play a role too. Breastfeeding has been associated with a lower risk of childhood asthma. But there's also evidence that in people with a strong family history of asthma, it might be linked to more asthma in adulthood, regardless of breastfeeding. And that really speaks to how genetics and environment interact. Air quality and allergens are another important one. Outdoor exposures to things like pollen or fungal spores can make asthma worse. And there's growing research showing that air pollution or pollutants like PM 2.5, nitrogen dioxide, or ozone may increase the risk of developing asthma. For indoor exposures, we also need to think about allergens from house dust mites, mold, or pets. But here it gets tricky. Some studies suggest that early exposure might help build tolerance, while others show that it may actually increase sensitivity. So the science is still evolving. And then there's what everybody talks about, that is the microbiome. All those microbes in not just in our airways, but in our guts may really affect our risk of having asthma. The hygiene hypothesis suggests that kids who grow up in very clean environments or take a lot of antibiotics early on may not actually develop a strong immune system. A diverse microbiome seems to help train the immune system and potentially protecting them against asthma and allergies. So while we may not be able to change things like family history or our genes, there's still a lot we can do, like reducing exposure to smoke, improving indoor-outdoor air quality or the exposure to air pollution, and supporting microbial diversity in early life. It's an exciting area of research that may actually help prevent asthma from developing in the first place. I was reading the WHO newsroom, and they issued a special piece just a few weeks ago, and that's titled Air Pollution, Tackling a Critical Driver of Global NCD, the Non-Communicable Disease Crisis. So, and in that article, if I remember correctly, they were saying that air pollution is the second leading risk factor for NCD after tobacco smoking. And they named air pollution a silent threat to every organ, not just our lungs, but every organ, as it affects virtually every organ and system in the body. And they actually quantified the impact of air pollution, and they stated that 83% of premature deaths due to air pollution, and they are from chronic diseases including ischemic heart disease, stroke, lung cancer, and COPD. So despite there's a critical driver of global NCD burden, air pollution often remains overlooked in the global NCD response. And that's not just, policymaker, clinicians, but also us, the public. We often really ignore that air pollution, climate change is there, that we are living in the middle of it, and we are affecting by it. So I think there's still a lot of education to the general public how to deal with air pollution and climate change. Of course, purely lockdown, even though we're quite used to lockdown because of the COVID pandemic, but just lock down and stay at home because of there's air pollution outside may not be a good and long-term viable solution. So we need to know what are the alternatives. And one of the things that I think we need to know is how to really be smart about exposure to air pollution, to environmental exposures in general. When it comes to air pollution, if you may know, Josh, there's an app, or you could if you don't have an app, you could also access that on the website that Environment Canada and Health Canada they posted, and they announce and they push it through the app, the air quality in areas in Canada, in Ontario, in many provinces, by very local, regional level. So you would know, even before you go out, if you want to jog in your neighborhood, it may be smart to really check what is the air quality in my area. And if it is very high, then you may not want to go out at that time of the day, right? That doesn't mean that you should not go out, period. You should find out what is the best time to go out and jog in my neighborhood, or go to another neighborhood that the air quality is better to do exercise. So I think we need to be air quality smart, like street smart, but air quality smart, so that, whatever we do won't really harm us, would only benefit us.
That's great advice, and not just for asthmatics or COPD sufferers or what have you, but really for everybody, because like you said, it's bad for every single organ in the body.
Yep.
You've emphasized the importance of early identification and personalized treatment. What does early intervention look like in practical terms for kids with asthma?
Yeah, that's the important question. Early intervention is so important when it comes to asthma, and not just to keep symptoms under control, but to protect kids' lungs long-term while they are still developing. The first step, of course, is to getting an accurate diagnosis early using objective tools like spirometry, if and when the child is old enough to do so, and not just going by symptoms. Once a child is diagnosed, we typically start them on inhaled corticosteroids, ICS, as soon as possible. And these help calm the inflammation in the airway and can prevent airway remodeling and lasting damages to the lungs. A big part of early intervention is also having a personalized asthma action plan. And asthma action plan is something that is concrete, that families can follow. It lays out what to do if symptoms get worse, and how to adjust medications and when to seek help. It gives family a sense of control rather than feeling like asthma is controlling them. We also spent a lot of time identifying and reducing triggers like allergens or irritants. And that might mean using dust mite covers, improving ventilation, or reducing exposure to smoke that we talked about earlier. Families can keep a symptom diary and work with their care team to spot patterns and make changes at home and at school. Medications is another important piece, and understanding how to use them matters. Inhalers need to be used properly, and spacers or breath actuated devices often help kids get the medication deep into their lungs. And we also encourage monitoring over time with tools like peak flow meters, and these may detect symptoms before or problems before symptoms even show up, so families can take action early and avoid emergency visits. Ultimately, early intervention helps kids live normal, active lives, go to school, play sports, sleep well, all without asthma getting in the way. And looking forward, we need to keep improving how we identify high-risk kids and tailor treatments earlier. So,
absolutely. And a couple things that stand out big to me that in that answer that you had, individualized asthma action plans. That is huge. That is super important because we're all built just a little bit differently. We all have our own triggers. I love that. I think it's important. And for the parents to sit down with their kids and really create a checklist, a symptom checklist or a trigger checklist, you name it, everything they can. All information is good information in those regards. And it's all going to help prevent future emergency room visits.
absolutely.
Across Canada, there are still significant gaps in how asthma is diagnosed and managed, especially among marginalized communities. What barriers do you see most often, and how can we begin to address them?
Yeah, that's a good question. Yes, we still see some really big gaps in asthma care across Canada, and unfortunately, they're often in marginalized communities. In my opinion, one big issue is research funding. Asthma is the most common or prevalent chronic condition among children, and yet in 2024, it received the least research funding from CIHR, the Canadian Institutes for Health Research, compared to other top chronic diseases. And that lack of investment limits innovation and may also contribute to health inequities. Another major challenge or barrier is how we diagnose asthma. The gold standard is to use objective tests like spirometry to confirm variable airflow limitation. But in real life, that doesn't always happen. A study or a review conducted by Dr. Sean Aaron and his colleagues at the University of Ottawa show that 30 to 35%, that is more than a third, of people diagnosed with asthma might not even have it anymore or never had it in the first place, and yet they were put on asthma medications. So if you performed spirometry on them, it showed that they actually did not have asthma because the right tests weren't done or because no one reassessed them. And the study also reported that 20 to 70% of people with asthma remain undiagnosed and untreated, and often due to underreporting of symptoms or barriers related to poverty and access to care. And that misdiagnosis, both under and overdiagnosis, leads to poor outcomes and wasted resources. And there's even now emerging research that shows that untreated asthma in childhood may increase the risk of COPD later in life. So the stakes are high. We also see that asthma awareness is low, still low. Many people don't recognize the signs of uncontrolled asthma, especially severe asthma, so they delay seeking help. Access to care is a huge issue. Not everyone has a regular doctor, or seeing a specialist can be difficult, especially in rural or under-resourced areas. And then there's the cost, right? Even with insurance, many families struggle to afford inhalers and spacers. So medications get skipped and symptoms worsen and kids end up in the emergency rooms. And we also learned from one of our research projects that asthma can run in the family. So you could have more than one kids have asthma. So medications are shared among siblings. So if you have asthma, it's fair up, you take it. And if I don't, then I skip it. So sharing medication is not ideal. So, and partly it's because of the cost of medication, and families cannot really afford it for every child with asthma. And on top of that, we talked a little bit about that already. Environmental and social factors like poor quality housing or air pollution tend to hit low-income communities hardest. And these are the same communities with higher asthma rates and worse outcomes. To address these barriers is not simple. We can identify them, but to solve them, address them is not as straightforward as we imagine. We need better coordination between primary care and specialists, more outreach and education in communities, and policies that make medications and clean air more accessible. In my opinion, equity in asthma care isn't optional. It is really essential.
I had a recent conversation with Dr. Paolo Pianosi, which is recently retired from the Mayo Clinic in Rochester. Amazing to have on, by the way. And growing up, he was my own specialist and my respirologist when I was at the Sick Kids in Halifax. So to have him on now, I'm 35 years old, was absolutely amazing to get to speak with him. And we went over things that I couldn't have covered when I was younger. So biologics were just coming out. To drop a name, Xolair. Xolair was coming out. Now, I can't remember exactly the price of the medication, but we'll say $2,000 a shot every couple of weeks. Now, we grew up in poverty. Insurance wouldn't pay for that. It wasn't realistic for me. Well, I wasn't able to get on it, unfortunately. I know that would have helped me greatly. But had I been on it, how much money would that have saved the healthcare system? I mean, I'm sure it would have saved a lot of money in the healthcare system that could have been utilized elsewhere. And what really sticks out when you mention how asthma research is really underfunded is your presentation at the Mercado. If you know the numbers, feel free to drop them. I think it'll help paint a picture for everybody listening.
Yeah. And, I was also, shocked by my own finding when I combed through what's being funded by CIHR. Of course, CIHR is not the only funding agency for health research, but it is the federal agency in Canada that funds health research. So I actually looked at their database in 2024. That's the most recent data that is available. And I looked at the top 5 chronic diseases in Canada. That's cancers, heart disease, COPD, diabetes, and asthma. And it's great, for all the other top 4 chronic diseases. They received hundreds of millions dollars for health research, and rightly so. We are not trying to suggest to take away money from these areas to fund asthma, but there is a imbalance. When you look at the prevalence of chronic disease, asthma, in fact, is the most prevalent chronic disease in Canada. It's about, based on the Asthma Canada estimate, it's currently at the 4.6 million individuals in Canada living with asthma. That is the most prevalent chronic disease in Canada. So if you factor that into the equation, then, you could calculate how much research money is invested in each individual with these chronic conditions. And, we calculated that, for asthma, for cancers, for example, the funding for cancer is $300 million for slightly under 1.6 million people in Canada with cancer. And so that's $133, almost $200 per person with cancers. and maybe cancer is not a fair comparison to asthma, but diabetes maybe is a closer comparator to asthma, because diabetes can also affect very young people at a young age, and so is asthma. So diabetes in 2024, they received over $110 million for about 4 million people with diabetes. So if you calculate that's CIHR is investing $28 per person with diabetes in 2024. And asthma, how much money did we receive from CIHR in 2024? Is slightly under 6 million. Is not hundreds of millions. Is 6 million. Whereas the other 4 chronic diseases, they're all over $100 million. So asthma received slightly under $6 million for 4.6 million people living with asthma. So if you calculate that, that's about $1.30 per person living with asthma. And that's the investment. In my opinion, it is great that the government is still investing research money in asthma, but it is inadequate. We are definitely underfunded in pushing innovations for asthma. So I hope that our voice will reach somewhere, that it will help raise awareness of asthma research. We're not done. We've done a lot of good things in asthma care, asthma research, but we are not done. We still need funding to help us promote asthma research and generate innovation and improve asthma care.
As an individual who has suffered from severe asthma my entire life, and it's really defined my entire life, it's hard to hear that, a little over $1 really per asthmatic is put into research. So hopefully, as you said, this reaches someone somewhere or the right people. And I think we're going to get there eventually. I just hope it's sooner rather than later. I'd like to move on now to research highlights and big data insights. You've led some incredibly impactful studies using big data and linked health records through ICES. How has access to large-scale population data transformed what we know about pediatric asthma?
In my opinion, big data has been a game changer. And Ontario has really led the way on this with the support from the Ministry of Health and ICES, which is formerly known as the Institute for Clinical Evaluative Sciences. We developed the Ontario Asthma Surveillance Information System, in short, OASIS. It's a registry built using linked health administrative data, and it has been tracking everyone in Ontario with asthma since the mid-1990s. And right now, it follows over 2.4 million people with asthma, from kids to seniors, and one of the biggest population-based asthma cohort in the world. And that means with OASIS, we can see the big picture. For example, OASIS reports that in Ontario, about 41,000 new asthma cases being diagnosed every year, and with 13,000 asthma hospitalizations, 30,000 asthma ED visits, and over 600,000 doctor visits for asthma, costing more than $130 million healthcare costs annually, just in Ontario alone. But more than just counting cases and numbers, OASIS helped us understand patterns. Where are the gaps in care? How are treatments being used? And what happens over the long term? And how do things like comorbidities or social factors affect outcomes? From a policy perspective, that's incredibly powerful. Decision makers can use this data to design smarter, more equitable asthma programs grounded in real-world needs and real-world data. So for me, big data isn't just numbers. It's a way to improve care, plan better systems, and ultimately change lives for people living with asthma.
You spoke about the OASIS program, and through the OASIS program, you're working to advance integrated care for children with asthma. What are some of the most promising findings or innovations to come from that work so far?
We've done a lot, as I mentioned earlier. We've been doing that for decades now. We often fear about the lifetime risk of developing a disease like diabetes, cancer, stroke, or heart disease, but rarely do we talk about the lifetime risk of developing asthma. In fact, few people even know what that risk is. So using the data from OASIS, we actually calculated the lifetime risk of asthma. We found that nearly 18% risk or probability of developing asthma by age 10, and over 21%, that's 1 in 5, by age 20, and nearly 34% by age 80. And that means more than 1 in 3 Ontarians will develop asthma in their lifetime. And that just shows how common and how important this condition is. Asthma is a major public health issue that affects many across all ages and our lifespan. Knowing this lifetime risk supports strategies such as early detection and prevention that we talked about earlier, health policy and planning, research and innovation. And furthermore, we're using OASIS data. We've also looked at emergency department visits. We found that among people who go to the ED for asthma, about 1 in 8 come back within a year. And that tells us there's a real opportunity to intervene early and reduce repeat visits. With the right support, we can prevent those flare-ups, improve quality of life, and save healthcare costs. Another exciting area has been the collaboration with Health Canada. And using OASIS data, we study how air pollution impacts health. We found that exposure to ozone raised the risk of developing asthma by 17% and nitrogen dioxide by 7%. And these pollutants were also linked to high rates of eczema in kids. So air quality really matters, not just for asthma, but for allergic diseases more broadly. We also found that cumulative or continuous exposure to air pollution, particularly PM 2.5 and ozone, increases the risk of COPD in people who already have asthma. We found that every unit increase in these air pollutants exposure increases the risk of worsening asthma to COPD exponentially. So building public awareness of air pollution and the understanding of its impact on health is really paramount.
Your research has also explored vaping among youth and its impact on asthma. I recently had Jessica Buckley, which is the CEO of Lung Health Foundation, and we discussed vaping among youth as well. And unfortunately, data really only goes back about 10 years. What do we now understand about vaping as a risk factor for respiratory illness, and how should clinicians and educators respond to that?
Yeah, that's a very important area. Vaping among youth is a serious concern, and some actually call it an epidemic or an urgent public health crisis, especially when it comes to respiratory health and asthma. The WHO actually has warned about how e-cigarettes are being aggressively marketed to young people with flashy packaging, tens of thousands of flavors, and designs that make them look fun or harmless. And social media plays a huge role to platforms like TikTok and Instagram are full of videos glamorizing vaping, tricks, hacks, and influencers promoting their products. Between 2019 and 2020, TikTok had over 1,000 vaping-related videos and racked up nearly 2 billion views. Imagine, even a brief exposure to that content makes young people very vulnerable and more likely to try vaping and to see it as safe. Unfortunately, that's very far from the truth. Many young people think vaping is safer than smoking, but we are still learning about the long-term risks of vaping. And what we do know is really concerning. E-cigarettes contain nicotine, ultrafine particles, heavy metals, and other harmful substances. As we know, nicotine is highly addictive and can interfere even with brain development. Our research shows that many young people who vape also smoke cigarettes. They are what we call dual users, and they tend to have worse health outcomes, more healthcare use, and more mental health challenges. In one of our studies, we found that female vapers had nearly twice the healthcare use compared to male non-users. Our data also show that even if they are physically active, young vapers report higher levels of life stress. So vaping is not a healthy way to cope, and definitely not a safe alternative to smoking. We need stronger policies to regulate these products, no doubt, especially for minors. We also need public health campaigns and school-based education, and we should be using the same platform that are driving the problem to help solve it. And Instagram can be part of the solution if we use them strategically. And clinicians, educators, and policymakers all have a role to play, and we have to act fast to protect this young generation from a growing epidemic.
You've also worked closely with schools and public health systems. How are your findings being translated into real-world or policy?
That's a good question. For me, research is only meaningful if it leads to real change, especially when it comes to kids living with asthma or other chronic conditions. For me, a big part of that has been through the OASIS program that we talked about earlier, which I have led for over 2 decades now. The data we generate doesn't just sit in journals. It's being used directly in health system planning, policy decisions, and chronic disease management across Ontario. We also worked with both the Ministry of Health and Ministry of Education to improve asthma care pathways through programs such as the PCAP, which stands for Primary Care Asthma Program, which is coordinated through the Lung Health Foundation. And these programs make it easier for schools and families to manage asthma proactively and reduce unnecessary ED visits. And more recently, we've also started linking clinical, administrative, and environmental data with newer digital tools and AI. And that lets us turn very complex evidence into practical tools that policymakers, educators, and healthcare providers can actually use. For example, the MOCA study, and MOCA is short for Mobile Kids Asthma. And that is a project led by Dr. Simon C. at St. Justine University of Montreal. It is an innovative mobile health, mHealth, research project designed to better predict and prevent severe asthma attacks in children. The MOCA study is an exciting step towards digitally empowered asthma care by combining symptom tracking, audio monitoring, and environmental feedback on a mobile platform to help prevent severe pediatric asthma exacerbations. So at the end of the day, the real impact happens when we bring research, policy, and frontline care. And that means working hand in hand with the people who deliver services and support families every day.
It's a great and well-detailed response, Dr. To. Thank you for that. I'd like to move on now to mentorship, equity, and collaboration. You've mentored many young researchers and public health professionals over the years. Why is mentorship so important to you, and how has it shaped your own career?
Oh, wow. Mentorship has always been a core part of my work, not just something I do, but something I really believe in and value. It's how we build the future of public health and science. Early in my career, I was absolutely very lucky to have mentors who believe in me, who gave me the space to grow as a researcher, an epidemiologist, and a teacher. Their support shaped my career and my mindset, and that doing great science also means lifting others up. And over the years, I have had the privilege of mentoring so many amazing people, clinicians, researchers, public health professionals, many of whom are now leading their own impactful work, whether it's through SickKids, the University of Toronto, ICES, or OASIS. I've always tried to create environments where critical thinking and curiosity are encouraged and where everyone feels they belong. And honestly, mentoring has made me a better scientist. It keeps me connected to fresh ideas, different perspectives, and evolving challenges, whether it's AI in asthma care or tackling equity issues more directly. Mentorship has shaped my career, and I'd say is what has kept me grounded and inspired all along the way.
Much of your work happens at the intersection of research, healthcare, and policy. How important is collaboration in advancing asthma care and public health? You did mention before that it leaves you open to essentially new ideas. And with AI coming out with all these new ideas today, well, I mean, that's an answer in its own. But can you expand on that a little bit?
Yeah, collaboration. Collaboration is absolutely essential, not just in asthma care, but in public health more broadly. Honestly, I wouldn't have a career without it. Asthma is a complex condition. It cuts across environmental exposures, biology, healthcare access, and social factors. So we can't make progress if we stay in our own silo. Research alone isn't enough, and clinical care alone isn't enough. We need to work across disciplines and sectors to create real solutions. And take OASIS, for example. That program only exists because of partnerships between clinicians, data scientists, policymakers, and community health leaders. And again, another example is MOCA that I mentioned earlier, that we collaborated with Dr. C in Montreal. It exemplifies how mHealth strategies can translate clinical research into that families can use every day. That wouldn't happen without multidisciplinary collaboration between pediatricians, epidemiologists, data scientists, implementation experts, and not to mention patients and families. And these collaborations have shaped the way I think, the question I ask, and how we apply our findings, helped ensure our work stays rooted in the real world and not just the lab or academic journals. So to me, collaboration isn't just important, it's the foundation of everything meaningful that we do.
You've also been a strong advocate for gender equity and women in science. What's your message to young women, and especially young women of color, entering the field of health research?
Well, as someone who entered this field decades ago, as both a woman and an immigrant, I can say the path hasn't always been easy, but it has been deeply meaningful. My message to young women, especially women of minority, is simple. You belong here. Your voices, your experiences, your perspectives, they're not just important. They're absolutely essential to move science and public health forward. What helped me along the way is having mentored who believe in me that I mentioned earlier, and building networks of support with people who genuinely wanted to lift each other up. I wouldn't be where I am without that community. I've also seen firsthand how diverse teams produce better science and more relevant solutions. And that's why I've tried to pay it forward, mentoring, encouraging, and creating space for women and unrepresented voices to lead. So to anyone, everyone, starting out, bring your curiosity, your determination, and your voice. Find allies who support you and challenge you to grow. And don't hesitate to take up space, even when it feels hard. We need you. And not just to contribute to science, but to help shape and reshape what science looks like.
I love that, Dr. To. What a great answer. Thank you. So now we'll move on to guests' final thoughts and plugs. Before we wrap up, Dr. To, is there anything else you'd like to share with our listeners? Perhaps a new initiative you're working on, resources you recommend, or ways to better stay connected to your work?
Oh, absolutely, yes. A lot of our current work is really focused on the future of asthma care, especially how we can use digital tools and AI responsibly to improve outcomes. I know there's a lot of concern about AI, and that's fair. There are real issues around privacy, bias, and making sure it doesn't replace clinical judgment. But if we use it thoughtfully and ethically, AI can actually enhance what we do. And for example, in our MOCA study, I've already mentioned it a couple of times, we're using machine learning to help predict which children are at highest risk for asthma attacks. It's not about replacing care. It's about giving families and clinicians better information and sooner so they can intervene earlier. We're also doing promising work around biologic therapies that you commented earlier. These are new treatments that target specific parts of the immune system for kids with severe asthma who don't respond well to standard treatments. Biologics actually offer real hope. In a recent project that I'm involved in at Sick Kids, we saw early encouraging results. But there's still so much we need to learn. We're looking at things like optimal dosing, biomarkers to predict who will benefit the most from which biologics, and when to safely stop treatment, and how early intervention might make a bigger difference. That's where precision or personalized medicine comes in. If we can match the right treatment to the right child at the right time, we can deliver better care with fewer side effects and potentially change the long-term course of the disease. Digital health tools, personalized therapies, and AI can also help us close gaps in care that we talked about earlier, especially for underserved communities. But we have to make sure these innovations are inclusive, transparent, and grounded in real-world needs. In the end, AI and digital tools are just tools. They are only as good as the question we ask and the values that guide how we use them. If we get it right, these innovations could really help us manage asthma more effectively and even tackle some of the root causes that lead to disparities in the first place.
Thank you for that answer, Dr. To. Whether you have asthma or not, every breath we take is a gift, a reminder of our resilience, our drive to keep going, and our power to define our own limits. With a single breath, you have the potential to move mountains and change the world. So with that in mind, I have one final question for you. If you had only one last breath, but with it the power to influence the world, what would your message be?
I've spent my entire career in health data into decisions and solutions that may make a difference. I believe the future of asthma and public health for that matter, lies in using every tool at our disposal wisely and ethically. So if I had one breath left, I'd say through research, we've come so far from understanding asthma triggers to developing life-changing biologic, but we are not done. So let's continue to invest in clean air, early care, and the science and innovations that help every child, every person breathe freely, not just for a moment, but for a lifetime.
That's terrific. Dr. To, thank you so much for sharing your time, your wisdom, and your commitment to child health. Your work has improved the lives of countless families and helped shape a more compassionate, data-driven future for asthma care. To our listeners, if you found today's episode insightful, please subscribe, share it with those who might benefit, and leave a review. For more information on Dr. To's work, including links to OASIS, ICES studies, and other asthma resources, check out the show notes. Until next time, keep pushing forward, keep breathing deep, and never let anything hold you back.
Thank you for listening to Beyond the Wheeze. If you enjoyed this episode, don't forget to subscribe and share. Follow us on Instagram at Beyond the Wheeze, and or follow me at the Asthma Runner for more updates. Keep breathing strong, and remember, your potential has no limits. Until next time.